Bismillahirrahmanirrahim. My name is Dr. Taimia Ayub, and today I will be giving presentation on monkeypox under kind supervision of Professor Dr. Saira Afzal. So we will start with the quote of the day: keep your face always towards the sunshine, and shadows will fall behind you. This is the content outline we will be covering today. These are the learning objectives. By the end of this presentation, participants will be able to understand the epidemiological triad of Mpox, burden of Mpox. They will also be able to identify associated signs and symptoms, understand its transmission routes, diagnosis, and treatment. At the end, we will solve MCQs. So, I will start with the case scenario of a 24-year-old male presenting with a worsening rash that began in the genital area and spread to his face and body over 5 days, accompanied by a low grade fever. Physical examination revealed multiple umbilicated pox like lesions on the face and genital area, vesicular lesions on the trunk, along with palpable lymphadenopathy in the neck and inguinal region. These are the pictures of that patient. As you can see, there are multiple crusted papules in the figure A, and then there are uh, vesiculopapular rash, and the rash is in different stages. Laboratory tests showed elevated liver enzyme and normal chest X-ray result. STI screening was negative. 4 skin samples were sent for an Mpox monkeypox PCR test, which returned positive within 24 hours. This is the timeline of Mpox disease. As you can see, in 1958, a pox-like disease occurred in colonies of monkeys kept for research in Denmark. In 1970, the first human case of Mpox was recorded in a 9-month-old boy in what is now called Democratic Republic of Congo. Between 1970 to 2022, cases of Mpox were rare and usually linked to travel or to animals being imported from regions where Mpox is endemic. In 2022, unprecedented global outbreak began in the May. WHO declared Mpox a public health emergency of international concern (PHEIC) on 23rd July 2022. The first ever case of Mpox in Pakistan was reported to WHO on 20th April 2023. In 2024, WHO's Director General declared Mpox again a public health emergency of international concern. Global burden of Mpox. Since 1st January 2022, cases of Mpox have been reported to WHO from 127 member states across all 6 WHO regions. As of 30th November 2024, a total of 117,663 laboratory confirmed cases, 2 probable cases, including 263 deaths, have been reported. But overall, the number of cases worldwide have gone down steadily since the peak in 2022. So far, in 2024, there were nearly 9,000 cases of Clade 2 Mpox around the world. This is the global situation of Mpox in this figure. As you can see, there was a sudden surge of cases between June 2022 and November 2022, particularly in areas of European region and in region of Americas. But afterwards, these cases have gone down significantly. This figure is showing the global situation of Mpox with the region with the heaviest burden of Mpox. The dark blue areas are representing the countries with 10,000 plus confirmed cases. They include United States of America in the North America, Brazil in South America, and Democratic Republic of Congo in the heart of Africa. As you can see, Pakistan and India were fairly safe with only 10 to 9 reported cases. Mpox in Pakistan. On 2nd December 2024, the IHR, National Focal Point of Pakistan, notified WHO of its first case of Mpox due to Clade 1b monkeypox virus. As of 15th December 2024, a total of 13 confirmed cases and one death have been reported from Pakistan. This is a slight glimpse of Mpox, particularly in Democratic Republic of Congo, where children are one of the most highest group of people being affected. From monkeypox to Mpox, the World Health Organization renamed the disease from monkeypox to Mpox in November 2022 to follow World Health Organization best practices for the naming of new human infectious diseases. Those guidelines recommend that disease name should avoid offending cultural, social, national, regional, professional, or ethnic groups and minimize unnecessary negative effects on trade, travel, tourism, or animal welfare. Now we come to the epidemiological triad of Mpox. It includes three factors, which is agent, host, and environment. We will cover each of these one by one. First, we come to the agent, which is the Mpox virus. Mpox is a zoonotic viral illness caused by the monkeypox virus. It is an enveloped double-stranded DNA virus of orthopox virus genus in the Poxviridae family, which also includes variola, cowpox, vaccinia, and other viruses. This figure is showing the comparison of monkeypox virus as compared to HIV, SARS-CoV-2, and polio viruses. So now we come to the types of monkeypox virus. Monkeypox virus has mainly two clades, clade 1 and clade 2. Clade 1 has two subclades 1A and 1B. It is responsible for the current rise of cases in Central and Eastern Africa. Historically, clade 1 caused higher number of severe illnesses than clade 2, with up to 10% of people dying from it. But in recent outbreaks, there have been much lower death rate being reported of about 1 to 3.3%. Clade 2 with subclades 2A and 2B. Clade 2 is endemic to West Africa. In 2022 to 23, a global outbreak of Mpox was caused by the clade 2B strain. Infections from clade 2 Mpox are less severe and more than 99.9% of people survive. This figure is showing the endemic regions of clade 1 and clade 2 Mpox virus. The bluish purple color are showing the Central African region where clade 1 is endemic. These include Democratic Republic of Congo, Central African Republic and Gabon. The green regions are showing the areas where clade 2 is endemic. These include Nigeria, Ghana, Liberia. Cameroon is the country, as you can see, with both clade 1 and clade 2 being endemic there. Now we come to the host factors. Animal hosts such as African rodents, mice, prairie dogs, and non-human primates play important role in the development and transmission of the outbreaks. In human being, close or intimate in-person contacts with individuals who have suspected or confirmed Mpox or are part of a social network or community experiencing Mpox outbreaks, such as DRC. Recent travel to Central or Western Africa or other areas where large outbreaks of Mpox have been reported. So, the risk of severe disease is present in children, pregnant women, people with weak immune systems, including people living with HIV that is not well controlled. So, now we will cover the environmental factors. Mpox cases are directly associated with heat index. A study showed that for each 1 degree centigrade rise in the heat index, daily cases increased by 7.7%. However, higher relative humidity and wind speed were associated with decreased daily cases. Mpox transmission through wastewater, air, and the contaminated surfaces is a significant concern, and its detection and destroying will play a major role in controlling the spread of the virus. As Mpox belong to pox viruses, and pox viruses have a high environmental stability, but they are sensitive to all common chemical disinfectants. Transmission of Mpox. So there are three main ways of the transmission of Mpox. Animal to human transmission of Mpox occur from infected animals to human from bites, scratches, or during activities such as hunting, skinning, trapping, cooking, playing with carcasses, or eating animals, etc. The animal reservoir of monkeypox virus remains unknown, and further studies are underway. People can also contract Mpox from contaminated objects such as clothing or linen, through needle injuries in healthcare, or in community settings such as tattoo parlor. So now we come to the human to human transmission. It includes direct contact with rashes, scabs, or body fluid of a person with Mpox, close face to face contact, intimate activities, and sexual contact. The virus may spread through respiratory particles, such as from coughing or sneezing. Vertical transmission. A pregnant person who gets Mpox can pass the virus to the unborn baby. This figure is showing animal to human, and human to human transmission of the monkeypox virus. Phases of Mpox disease. The incubation period of human Mpox can range from 5 to 21 days, with a typical incubation period of 7 to 17 days. Incubation period is then followed by a prodromal period of 1 to 4 days. In this phase, there is usually fever and body aches. This is followed by a second active phase, which typically occurs after the fever subsides, with the appearance of skin and or mucosal rash, which might include single or multiple lesions. Signs and symptoms. The Mpox rash often begins on the face and spread over the body, extending to the palms of the hand and soles of the feet. It can also start on other parts of the body where contact was made, such as the genitals. It starts as a flat sore which develops into a blister filled with liquid that may be itchy or painful. As the rash heals, the lesions dry up, crust over, and fall off. This figure is showing the different stages of Mpox rash, starting from stage 1, which is macule, stage 2, papule, stage 3, vesicle, stage 4, pustule, and finally scabs. Apart from rash, which is the most common symptom of Mpox, other symptoms include fever, chills, sore throat, swollen lymph nodes, particularly in the maxillary, cervical, or inguinal region, headache, muscle aches, back pain, and low energy levels. Complications of Mpox. Complications of Mpox can include complications. Skin can become infected with bacteria, leading to abscesses or serious skin damage, pneumonia, corneal infection with loss of vision, pain or difficulty in swallowing, vomiting, and diarrhea, which can cause dehydration or malnutrition. Other complications include encephalitis, sepsis, myocarditis, proctitis, or urethritis. Mpox can be fatal in some cases. This is a figure which is showing the summary of what we have so far discussed, with exposure, variable incubation period, prodromal phase, and target organs. So now we come to the diagnosis of Mpox. Identifying Mpox can be difficult because other infections and conditions can look similar. Therefore, it is important to distinguish Mpox from chickenpox, measles, and other such conditions. The preferred laboratory test for Mpox is detection of viral DNA by polymerase chain reaction (PCR). The best diagnostic specimens are taken directly from the rash, skin, fluid, or crust, collected by vigorous swabbing, which you can see in the figure also. In the absence of skin lesion, testing can be done using swabs of the throat or anus. Testing blood is not recommended. Antibody detection methods may not be useful as they do not distinguish between different orthopox viruses. So now we come to the treatment of Mpox. According to WHO, to date, there is no proven effective antiviral treatment for Mpox. The goal of treating Mpox is to take care of the rash, manage pain, and prevent complications. Early and supportive care is important to help manage symptoms and avoid further problems. Case management of Mpox include number one, isolation, number two, symptomatic treatment, which is mainly supportive. Patient should be given antibiotic for fever, analgesic for pain, and fluids to maintain dehydration. To maintain hydration. Antiviral treatment. There is no specific antiviral treatment for Mpox, but some antiviral medication, such as cidofovir, have proven efficacy in treating severe cases. Infection prevention and control should be strictly implemented. Contact tracing should be done. Public health reporting. Confirmed cases of Mpox must be reported to local, district, and provincial health departments. Mpox vaccination. Getting an Mpox vaccine can help prevent infections. Pre-exposure prophylaxis. The vaccine can also be administered after a person has been in contact with someone who has Mpox. That is post-exposure prophylaxis. CDC recommends monkeypox vaccination for people who are known or possible close contact of people with Mpox. Know that one of their sex partners in the past 2 weeks has been diagnosed with monkeypox, or they have jobs that may expose them to orthopox virus, such as healthcare or public health workers and laboratory workers. So, there are many clinical trials of Mpox treatment being done. Some antivirals have received emergency use authorization in some countries and are being evaluated. These include FDA USA approved drugs such as tecovirimat, TPOX, and some other drugs. It is a priority to continue evaluation of therapeutics in robust clinical trials and to focus on optimizing supportive care for patients. So now we come to the level of prevention for Mpox, which are three levels: primary prevention, secondary prevention, and tertiary prevention. Primary prevention include health promotion and specific protection. In health promotion, health education regarding spread of disease, avoiding contact with suspected Mpox patients, covering face with mask, and healthy sexual practices are included. For specific protection, vaccination, as explained previously, are the main point. In secondary prevention, early diagnosis and prompt treatment. In early diagnosis, differentiating from other similar viral diseases and through timely diagnostic tests. So now we come to the tertiary prevention, which includes management of complication and rehabilitation facilities. Recent updates. This is a paper published on 24 December 2024. Mpox mRNA 169 vaccine inhibits orthopox virus replication at intranasal, intrarectal, and cutaneous sites of inoculation. A single dose of mRNA vaccine induced high levels of neutralizing antibodies in mice and provided robust protection against lethal intranasal challenge with vaccinia virus. The vaccine prevented viral replication and spread from the site of inoculation. The level of protection was correlated with the dose of mRNA administered and the resulting neutralizing antibody titers. Passive transfer of immune serum from vaccinated non-human primate also confirmed protection. This is another paper which evaluated the effectiveness of tecovirimat, also known as TPOX, in Mpox cases, systematic review of current evidence. It is also published in December 2024. So this paper concluded that observational studies revealed that early administration of tecovirimat, especially within the first week of symptom onset, significantly improves symptomatic resolution, reduces the severity of the disease, and decreases the likelihood of hospitalization and complication in observational studies. However, the impact on viral clearance was inconsistent. So now we come to the multiple choice question portion. A 34-year-old man presented with fatigue and painful skin lesions on his face, hands, and genitals following recent travel to an area with an Mpox outbreak and attending a social gathering with close contact. Mpox is confirmed by PCR testing. What is the primary cause of Mpox? A. Fungal infection, B. Allergic reaction, C. Viral infection, or D. Bacterial infection?
C.
Yes, that is correct.
C.
C is the right answer, as you can see on the screen also. Okay, so now we come to MCQ number 2. What type of virus is the Mpox virus classified as? A. Retrovirus, B. Adenovirus, C. Orthopox virus, or D. Herpes virus?
C. C.
Yes, that's correct. C. Orthopox virus. In 2022 to 2023, a global outbreak of Mpox caused a havoc in the world. Which clade of Mpox caused this outbreak? Clade 1A, Clade 1B, Clade 2A, or option D, Clade 2B? Okay, so the right answer is D, option Clade 2B. The reference slide number I have given at the bottom, so you can check that slide also. What was the global situation of Mpox cases since the peak in 2022? Option number A, cases have declined since the peak in 2022. Option B, cases have increased significantly since 2022. There have been no reported cases since 2022. Or option D, the global situation remains unchanged since 2022.
B.
Uh,
A.
basically, yes, there was a peak in 2022, but after 2022, the cases have declined significantly after that peak. So the option A is correct. Okay, so MCQ number 5 is, what is the most common symptom associated with Mpox? A. Cough and sore throat. B. Rash that evolves through stages. C. Muscle aches and fatigue. Or D. Fever and chills. What is the most common symptom among all of these?
C. B. B. B.
Yes, option B is
Rash.
correct. Rash is the most common symptom which evolves through different stages. Okay, so MCQ number 6 is, what is the significance of prodromal period in the progression of Mpox? A. The prodromal period allows for early detection of Mpox. B. The prodromal period is characterized by severe complications. C. It is the period in which the rash first appears. Or D. It indicates the final stage of the disease.
C. C.
Basically, prodromal period is the time period before the rash appears, in which there are ambiguous symptoms like fever and muscle aches. So, it is that period in which Mpox can be detected earlier. So, MCQ number 7 is, what are the stages of Mpox rash? A. Macule, papule, vesicle, pustule. B. Macule, papule, vesicle, pustule, scab. C. Macule, papule, blister, and pustule. Or option D. Macule, papule, vesicle.
B.
Yes, option B is correct. There are 5 stages of the Mpox rash: macule, papule, vesicle, pustule, and then scab. So, MCQ number 8 is, which complication is not commonly associated with Mpox? A. Rash and skin infections. B. sepsis, C. lymphadenopathy, or option D. cancer?
D.
Yes,
D.
option D is the correct one, cancer. A 29-year-old woman presents with swollen lymph nodes and a painful rash with vesicular lesions on her hands, arms, and face, which developed a week after close contact with an infected friend. Mpox disease is suspected. What is the diagnostic test for Mpox? A. Direct microscopy. B. Detection of viral DNA by PCR. C. Antibody test. Or option D. Growth on culture media.
B.
B.
Yes. Option B is the correct.
B.
Detection of viral DNA by PCR is the diagnostic test for Mpox. So now we come to the last MCQ. What antiviral medication has shown efficacy in treating severe cases of Mpox? Option A, tecovirimat, also known as TPOX. B, remdesivir. C, oseltamivir. Or D, acyclovir.
A.
A.
Yes. Yes, option A, tecovirimat, also known as TPOX, is the one. This is the MCQ key. I will be posting the video of this lecture on the YouTube channel. And thank you very much for listening. Thank you.
Thank you very much. Very nice presentation, Dr. Taimia, especially